So we have one more talk before the break, and I'm really excited. So Dr. Justin Sanders is the Cappy and Eric M. Flanders Chair in Palliative Care Medicine, Director of the Division of Palliative Care, and Associate Professor in the Department of Family Medicine at McGill University in Montreal. He is also the Director of the Division of Supportive and Palliative Care at the MUHC. He received his MD in 2007 from the University of Vermont and subsequently completed a master's in medical anthropology from University College London in the United Kingdom as a US-UK Fulbright postgraduate scholar. Dr. Sanders was then a resident, chief resident, and faculty member in the Department of Family and Social Medicine at Montefiore Medical Center in the Bronx. In 2014, he completed a clinical fellowship in the Harvard Interdisciplinary Palliative Care Fellowship at the Massachusetts General Hospital. Following completion of a research fellowship at Ariadne Labs, a joint health systems innovation center at the Harvard T.H. Chan School of Public Health and the Brigham and Women's Hospital, he served as the American Associate Director of Innovation in the Serious Illness Care Program and attending physician in the Department of Psychosocial Oncology and Palliative Care at Dana-Farber Cancer Institute until finally moving to McGill, where hopefully he'll stay for a while. His research focuses on understanding and implementing interventions to improve care and communication equity and relationships between clinicians and people affected by serious illness. And his talk today is going to be focused on having those serious illness conversations. So please join us in welcoming him, even though he can't hear our applause.
Okay. Good morning. My name is Justin Sanders. I'm delighted to be here with you. I hold the Cappy and Eric M. Flanders Chair of Palliative Care, and I'm the Director of Palliative Care at McGill. In those capacities, I would like to add my welcome to the morning, and I'm really grateful to be here, at least virtually, with you today. And I will deliver a recorded lecture, and then I'll be back with you in person to answer questions. So let's get started. I would like to start by saying I have no financial conflicts of interest. I do like to acknowledge, however, that I am a white, cisgendered, able-bodied, and heterosexual middle-class married palliative care physician and researcher. Why is that important? Well, I think of these as the lenses through which I view the world. They're also the lenses through which I try to look around in my work as a researcher and as a clinician. And I think that it's really important while I won't talk about it in detail today, it's really important that we understand sort of what are the identities that we bring ourselves to the communication that we have with patients, because they are the source of sometimes conflict, sometimes connection. And I think when we recognize those, we are much more effective communicators. At the end of this presentation, my hope is that you will recognize the unique communication needs of people affected by serious illness, that you'll describe at least 3 fundamental skills in serious illness communication, and also that you'll gain familiarity with a structured tool to support serious illness conversations. I will be addressing 4 of the key competencies related to being a successful communicator as they're articulated in the CanMed's competency framework. You can read these here. And I'd like to start off with some definitions and assumptions. So first of all, what in the world is a serious illness? If we're going to talk about serious illness communication, we should be clear about the population with whom or about whom we're talking. So a serious illness is a health condition that carries a high risk of mortality and either negatively impacts a person's daily functioning or quality of life, or excessively strains his or her or their caregivers. This is a consensus definition that was articulated by Amy Kelly around 2014, and I think guides a lot of our work in serious illness. So what then is serious illness communication? Well, I think of serious illness communication as the skills, behaviors, and tasks that are relevant to communication with people affected by serious illness. So they may include things like responding to emotion, ask, tell, ask, and using silence, all of which we'll talk about today. They may also include the tasks like breaking bad news or delivering prognosis or advanced care planning. And then serious illness conversations comprise another subset of these, and these are conversations to elicit goals and values in the context of a shared prognostic understanding. They can be structured or unstructured. We'll talk about a structured approach today. They can be thought of as related to, but distinct from other serious illness communication tasks, and they ideally happen early in the course of a serious illness. Why is that so important? And why is prognosis such an important part of this, or prognostic understanding? Well, if you think about it, way too often people arrive at the end of their life almost like a car crash. They find out, having not expected as much, that all of a sudden they or their loved ones are dying. What these conversations give us in making sure that people understand what may or what is likely to be ahead, and to understand what's important to them, is it gives us an opportunity really for them to help them plan in ways that shape how they spend their time, no matter how much time is left. And if you ask someone about what's important to them and they think that they have many years left to live, they may say that certain things are very important that otherwise, if they thought that time was short, might be very different. So what are some of the features of having a serious illness that are relevant to communication? Well, of course, there are physical discomforts due to the diseases themselves or treatments, complex decision-making that involves trade-offs. And what I mean by that is that with every decision in the setting of serious illness, it almost feels like there's no perfect decision, because there are trade-offs, because there are risks and benefits to every decision. And some of those become much more acute in the setting of serious illness. There are treatment decisions that involve risk of hastened mortality or prolonged dying, and heightened anxiety for patients and families. And what I realize is what I might have added to the slide about serious illness, the definition for serious illness, is just some concrete examples. So what I'm talking about here are things like advanced or metastatic cancer, end-stage organ disease, whether that's the liver, the kidneys, the lungs, and neurologic diseases like ALS. So I want you to take just a few seconds and think about your experience of communication in this context. I'm obviously not with you to be able to ask you in the room, but I want you to hold in mind what this population, what your experience working with people with serious illness, or what your experience with communication has been, just so we can ground ourselves for a moment in your real experience. Okay. So let's talk about some foundational skills in serious illness communication, the first of which is responding to emotion. And we're going to talk about this acronym called NURSE. In general, I hate acronyms because I can't tend to remember them, but this one I can remember because I work with nurses all day long. And this is a way in which we think about how to respond to emotion. So the N in NURSE stands for name. And this is about just stating a patient emotion. So you might say things like, I wonder if you're feeling sad about the test result, or I can see that this is making you angry. We typically say to avoid using the word angry, in part because anger has such a negative and a kind of a shameful connotation in our society. But you might say, I can see this is really upset. Naming gives structure to an unstructured experience. And it's not entirely different from, if you're a parent taking care of children who, when they're young in particular, they don't often have a language to give shape to a set of emotions. And part of what we do when we name that is we contain it to some degree. And so if someone's feeling really overwhelmed, and we can say to them, this is so overwhelming, this feels so overwhelming. Or if someone feels that something is unfair and you say, this feels really unfair. But in that way, we help contain a difficult emotion. Understanding is about empathizing with and legitimizing patient emotion. So you don't want to say, I understand what you're going through, because in some ways we can never understand what someone's going through. But we can say, I can imagine how scary this must be for you. Or many of my patients feel discouraged when they aren't seeing the response they want. So it makes sense that you feel this way. You might also say, I can't even imagine what you're going through. And in some ways, like an inverse of understanding. The R in NURSE stands for respect, and this is about praising patients for their strength. You can say something like, you've done a really great job at keeping everything in perspective. I applaud you for your courage in all of this. Or in the case of caregivers, you might say, you've done such an amazing job taking care of your loved one. And that also helps sort of contain or decrease the intensity of emotions. Support, which is the S in nurse, is about just stating your support. I think one of the things that people face in the setting of serious illness is a legitimate fear of abandonment by those who care for them. And showing your support is a way of helping address a difficult emotion that may be related to that. So you might say, I'll be with you until the end, or no matter what happens, I will always be your doctor. And really, that's a beautiful thing to say. And then finally, the E in nurse is to explore. So this is really about asking patients to elaborate on their emotion. Tell me more about what's upsetting you. What do you mean when you say this is not going to happen to me? Or I always find it useful to find the emotion and then try to understand what's really underlying it, because we may not know. So you might say something like, it seems like you feel really sad. Can you tell me what makes you feel most sad? And then we can really sort of break in, sort of find the cracks in a difficult emotional experience, and in that way kind of break it down. Why is responding to emotion so important? It's important because emotion colors our experience of everything. Okay, so people who are familiar with organizational culture will have heard the expression that culture eats strategy for breakfast. No matter how well you plan, the culture will determine what happens to some degree. And I always think that like emotion eats information for breakfast. In medicine, we sort of often think that our primary goal of communication is to provide information, but sometimes when people are in a state of aroused emotion, it's hard for that information to sink in or be utilized in some way. And so when we respond to emotion, we make sure that people are able to best use the information that they have. Another way to respond to emotion, which I just want to call out, is silence. Of course, we can be silent because we don't know what to say, or we can use silence as a therapeutic tool, and really as one of the most powerful forms of nonverbal empathic communication. And so, silence permits space to process emotions and information. It demonstrates your willingness and ability to sit with discomfort, which is no small thing. And it really projects that you can be present through moments of difficulty. And I like to think of these skills that we practice in serious illness communication as having a broader sort of meta goal, which is about helping people understand that we can be with them through a difficult time. It also models in some ways, and it's sort of a psychotherapeutic the way that they can communicate with others. So there's definitely ripples that come out from our use of these serious illness communication skills. The second is called ask, tell, ask. And this is really just a framework. So you ask questions to get on the same page, to gain permission, to gauge emotional states, to give control. You tell people things simply to be understood, and you ask people again to assure that they understand or to assess further needs. And so, for example, a physician in this case might say, would it be okay if I share with you my understanding of where things are with your COPD? And the patient might say, yes, that would be helpful. And the doctor might say, given this recent hospitalization and the new need for oxygen, I'm worried that things may get more difficult. And I think we should think about what to do if next time is more serious. And the patient might say, well, gosh, I hadn't realized it was so serious. And the doctor might say, I'll do everything I can to keep you out of the hospital. What questions do you have? Here's another example. The doctor might say, what have your other doctors been telling you about your illness since the last time we spoke? And the patient might say, well, my cardiologist hasn't said much. I just saw her recently. What do you think? And the doctor might say, well, I hope that you continue to feel well with the medications that you're on, but I'm also worried that at some point the medications may not work as well, and we should plan for that. And the patient might say, gosh, that sounds serious. And the doctor says, I know that sounds serious. With all that's happened with your heart, can you tell me about what you're most worried about? So you can see embedded in this is some of those ideas that are present in the nurse framework. The third is tell me more. And this is, it might seem strange to think, okay, well, these are just words. How can a word be a skill? And it's really not the word, it's the words themselves that are the skills, but they're about the recognition for applying an approach, in this case, spoken word, to address something that helps meet the situation in ways that help make it better. And in that way, it's not so different from a surgical instrument. You kind of recognize what is the right scalpel or probe, and you apply it in the right setting. And so that's helpful not only because it helps us become more effective communicators, but also because it helps us teach communication. Because a lot of these things, I'm certain, all of you do frequently, but recognizing them gives us some sense of spatial awareness in the conversations that we're having so that we can teach others about what goes well and what doesn't go well. So in terms of tell me more, this is a useful when you don't have complete understanding, or even when you're not sure what to say. As sometimes happens, we're confronted with times where we're kind of speechless. And so this is going to be useful to sort of pull out of your back pocket. Patient might say, I'm really not sure how to tell my family this news. And the doctor might say, well, tell me more about what feels difficult about telling them this news. Patient might say, I feel really overwhelmed. And the doctor might say, tell me more about what feels most overwhelming. Now, I realize this, I'm using doctors here. It's my own bias as a physician, but this is obviously useful for clinicians of all types. So a fourth is reflection. And reflection is really powerful. And it might sound silly, but we think of reflection in two ways. We think of it as simple reflection and complex reflection. You can break them down into those two categories. A simple reflection is very simply almost like an echo, reflecting something back to someone. So someone might say, I feel really worried about what's going on with my dad. And you might say, sounds like you feel really worried about what's going on with your dad. Someone might say, I'm feeling really, short of breath. Sometimes he says, sounds like you're feeling really short of breath sometimes. Now that sounds kind of silly that we would just simply say back to someone what they just said to us, but it's a really powerful way of helping someone feel heard and understood in a conversation. Okay. And it also helps move conversations forward. Now, what does so even more so is what we call a complex reflection. And a complex reflection is the idea that we're stating something that is kind of not directly been said, but kind of underlies the surface. So a classic example would be, for example, when someone says in the setting of serious illness, I'm really worried about talking with my kids about it. And, we think, what is the it? Often the it is something like dying. And so we might say, is it that you're afraid of talking with your family about dying? And it can be framed as a question or a statement. It sounds like you're really worried about talking with your family about dying. And in some ways, it's like a hypothesis. We don't know that that's for sure. They could say, oh, no, that's definitely not that. I'm actually not afraid of dying at all. But you can see how, if that was the case too, it would move the conversation forward. But it also creates space when you're willing to name something that hasn't explicitly been stated, that kind of makes it okay to talk about. Okay, because often the things that go unstated are the things that are most important. I'm thinking, as my computer stacked on a pile of Harry Potter books, I'm thinking about the word Voldemort. Like, we don't want to. There are things that shouldn't be named, but actually, when we give names to things, we kind of diminish their power in some ways, and so that's what's powerful about a complex reflection. Okay. So I just want to sort of pause for a second and say that while we're talking about communication, these are not soft skills. And in fact, these are the hardest skills to master. And often we're resistant as clinicians to the idea that these are skills because, we communicate all day. It's something that we can't escape, right? We communicate in multiple forums, multiple venues with multiple types of people. But these skills are the ones that give us, or these situations, these communication encounters with people affected by serious illness, which are often thought of as kind of difficult conversations, are really hard to master. And so I just want to put that out there because we delegitimize them in some way when we think about them as quote unquote soft skills. And so let's move on. Okay. Serious illness conversations. So again, these are conversations to elicit goals and values in the context of a shared prognostic understanding. And what I'm going to share with you today is a structured approach that was developed by colleagues and myself, or including myself, at Ariadne Labs, which is a health systems innovation center in Boston at the Harvard T.H. Chan School of Public Health and the Brigham and Women's Hospital. And so this is a serious illness conversation guide that sort of brings this structure to life. And this is patient-tested language. I'm going to run through it that really reflects sort of what we think of as best practices in serious illness communication. Now, you'll recognize that the questions that are in here are questions that I'm sure all of you have asked. And really, this is about putting it all together in a way that makes makes us more efficient at this work, okay? And I'll tell a brief story, which is that this guide kind of originated in a conversation between Atul Gawande, who's a surgeon and a writer, formerly based in Boston, now working for the U.S. government, who went around. He was writing an article about taking care of people who had a serious illness and who were referred to him as a cancer surgeon, but for whom he didn't really have a good treatment, or he wasn't sure that his surgery was going to be able to be helpful to them. And so he went around the country asking palliative care specialists, like, what's your checklist? How do you do this? And a lot of people, as you can imagine, were like, this is not a checklist. Like, having conversations with a serious person with a serious illness cannot be boiled down to a checklist. But then he found his way to Susan Block, who was the director of the chief of the Department of Psychosocial Oncology and Palliative Care at Dana-Farber Cancer Institute. And he said to her, how do you do this? What's your checklist? And she said, well, I wouldn't think about what I do as having a checklist, but certainly there's some questions that you might that you might ask that can help you sort of navigate these conversations. And so Atul, who's a journalist, in some ways, wrote down these questions, and he went off into his work. Now, he called Susan Block a couple weeks later and said, kind of breathlessly, like, we have to meet again immediately. And he came to her and he said, these questions have completely transformed my practice. I'm having conversations with patients that I never have had before, patients that I've known for years in some cases, and we have to do something about this. And so that began a process and a discussion that led to the development of this serious illness conversation guide, which I'm going to walk you through now. Now, that happened many years ago. The first iteration of the guide that sort of became public was in 2012, and this guide was released just this last year. And it reflects really many years of experience trying to understand how to make this as widely accessible a tool, both in terms of how it's used by clinicians, but also how it's experienced by patients from different backgrounds, including a host of marginalized backgrounds, which may leave people in a position where they're less understanding of some of the words that were on the original guide. So here we go. So setting up the conversation is really important because patients, as much as clinicians, fear talking about the future. And so setting up a conversation in ways that is safe is really important, and that gives people permission. I'd like to talk together about what's happening with your health and what matters to you. Would this be okay? And if patients agree, then you might assess sort of both their illness understanding and how much information or what kind of information is useful to them. So you might say, to make sure I share information that's helpful to you, can you tell me your understanding of what's happening with your health now? And then how much information about what might be ahead with your health would be helpful to discuss today? I spoke earlier about the fact that physicians traffic really in information, and Atul Gawande himself used to describe himself as what was it? Now I'm drawing a blank, but basically one who shares information just without thinking about it, and as a way of managing his own discomfort, really. And a shareaholic or something like that. But I think that describes many of our practices. When we're uncomfortable, we really think that what patients need more than anything is information. Now, the problem with that is that we don't often understand the kind of information that people are looking for. And so this is a way to help make sure that we can tailor information to what people are sort of hoping to, not what they're hoping to hear, but the kind of information that's most useful for them. So, people will have experience where people say things like, I'm not really interested in the details, but maybe you can give me the big picture. Okay, so the next section is about sharing, which is really about prognosis. It's about, and it has language that helps us share prognosis in ways that meet people's information preferences. Okay, and also that sort of meet the reality that we sometimes face in terms of certainty or uncertainty about illness. So, it can be, there's many times where we're not sure exactly. We know someone's sick, and yet we put them at risk of bad outcomes when we say things like, we don't have a crystal ball, okay, which really emphasizes uncertainty to a degree that isn't quite accurate, let's say. So we might say, it can be difficult to predict what will happen. I hope you will feel as well as possible for a long time, and we will work towards that goal. But it's also possible that you could get sick quickly. And I think it's important that we prepare for that. And you can see that this isn't definitive information. I mean, someone might say, well, what do you mean get sick quickly? And you might say, I'm worried that the next time this happens, you may not survive a subsequent round of this of COPD exacerbation or heart failure exacerbation. But it, creates the possibility for more understanding. If you wanted to emphasize time, which is often, more easy to do in the case of advanced cancer, you might say, I wish this was not the case, but I'm worried that time may be as short as weeks to months. It's important to express time as a range because all of us have had the experience of caring for someone who says, well, they told my uncle that he had 3 months to live, and 3 years later, he's still here. And so when we communicate time in a way that's like a single number, we kind of undermine trust because they know that that's not likely to be true. So when we communicate time as a range, we're acknowledging some of the inherent uncertainty while also helping people prepare. And the reason that's important, if I can digress for just a moment, is that prognostication is not about precision. Everything in medicine seems to be about precision. In fact, all of the dialogue in medicine today is about precision medicine, genes, and targeted therapies. And if we think about the importance of precision in diagnosis and treatment, that can't be underestimated. However, the purpose of prognostication is not precision, which really prevents us from communicating it because we know that we can't be precise. Really, it's about preparation. It's about helping people prepare in case the worst possible outcome happens. End of digression. Okay, so we might also communicate about function. It can be difficult to predict what will happen. I hope you will feel as well as possible for a long time, and we're going to work towards that goal. It's also possible that it may get harder to do things because of your illness, and I think it's important that we prepare for that. And then there's some instructions here to allow silence and to validate and explore emotions. And this is where you might use those nurse skills that we talked about at the beginning. It would be, we do a lot in healthcare to try to avoid upsetting people. And yet, if there's information that's upsetting and people aren't upset, then that's almost strange. Like we should expect that information that is difficult will upset people. And that doesn't mean that it's to be avoided. In fact, the opportunity to respond to a difficult emotion with our patients is something that builds our connection with them in ways that can have really profound effects. So, sometimes it can be difficult to talk about prognosis. And so sometimes we want to make sure we have a way out of it. And this is where we get into the section on exploring. So if your health was to get worse, what are your most important goals? What are your biggest worries? What gives you strength as you think about the future? So often we're focused on the things that are bad in people's lives, but actually people bring a tremendous reserve of strength with them based for whether it's due to their faith, their commitment to their family, whatever it is. And understanding that helps us care for people better, helps us support those strengths. What activities bring joy and meaning to your life? If your illness was to get worse, how much would you be willing to go through for the possibility of more time? This sort of acknowledges that there's trade-offs in every situation and gives people an opportunity to explore those. Many of us will have heard patients say things like, well, I really want to, I want to do everything I can, but I wouldn't do that. I don't want to live on a machine, for instance. How much do the people closest to you know about your priorities and wishes for your care? I think it's important to acknowledge that there's many decades of research that show that people just writing down what's important to them doesn't work. It's the conversations with the people around them, like their caregivers, that really have an impact on care when people can't make decisions. And so, trying to figure out like what is, how much do people know is really important. It can also inform recommendations moving forward. Having talked about all of this, what are your hopes for your health? And the idea here is that when we did this work with some validation work with patients in the last few years, we really heard that people want an opportunity to, to both digest all this information, to think about it, and then to sort of reconstitute in the way of what are they hoping for? Okay. And then finally, bringing it to a close. And this is really about making a recommendation and affirming your commitment to be with patients. So you might say, I'm hearing you say that that spending time with your family at home is really important to you, and that you're hoping for a lot more time, And so keeping that in mind and what we know about your illness, I recommend that we try to get the CLSC involved, which is for those of you who are not in Quebec, sort of local care entity, nursing entity where people can get care at home. But whatever it is, I recommend that we put in infrastructure in place to try to keep you at home as much as possible. And that may include like trying to, making a decision not to come back to the hospital at some point. This will help make sure that your care reflects what's important to you. How does this plan seem to you? Now, the important thing here is that you're checking in with the patient. You're saying, okay, this is not the plan, but this is what I would recommend. Like, how does that seem to you? And, patients want these recommendations because they often ask us for them. What would you do if it was your mom? What would you do if this was your sister? And we can give them we can sort of tell them what we recommend, and then see how it seems to them. They may say, you know what, I don't really think that's the right thing to do. And that's okay, because that moves the conversation forward helps you together find the right thing to do. And then finally, I'll do everything I can to support you through this and to make sure you get the best care possible. As I said before, patients affected by serious illness, particularly in the context of what we think of as difficult conversations, are often worried about being abandoned. And this is a way of affirming our commitment to them. So the words themselves aren't so important, the specific words. What's really important is however you can authentically convey to your patients that you care about them and that you're going to be there with them in whatever context feels appropriate is a really powerful thing to say. So all of this, communication is not an end, but what Balfour Mount, who's a McGill urologic surgeon who in the 1970s coined the term palliative care, early 1970s, said, what we're trying to do in palliative care and all medical care is to establish healing connections to be experienced by those who are ill or dying and their families. So with that, I'll say thank you, and I'm going to end this video and have an opportunity to be here virtually and synchronously to take your questions. But thank you for your attention.
Thank you. I started to say don't panic as I was panicking. But I believe that Dr. Sanders is here with us, and he's going to be, oh, hi, Justin. Oh,
hi.
Look. How are you? Thank you so much.
Hi, how are you?
We're very well. We're very well. We've all been actively listening to your presentation. It was a fantastic talk. Thank you so, so much. And now we do have time. We have about 10 minutes, which is good. We're back on track for any questions in the room. So if you do have any questions for Dr. Sanders, please come up to the mic, and I'm going to take a look at the chat to see if there are any questions there.
I'm also going to share my screen just for a moment. So if people are interested in locating this resource that I just described, you can take a picture or a screenshot or copy this URL, and that will take you to the newest version of the Serious Illness Conversation Guide that I was talking about. So I can leave that up for a second.
Oh, we have a question. So I'm not sure what you can see, Justin. I don't think you see us, but Dr. Zigbee is at the microphone, so he's going to ask a question.
Okay.
Hi, Justin. Can you see me?
I cannot. I can only see Bessie. But
well, far better that you see her, I have to tell you. So thank you so much for that talk. I have to say that it's a piece of magic that you look exactly like you did in that talk right now. And so
I'm in Southern California where magic happened.
That explains everything. So everything is just 3 hours delayed. And so my question actually is a comment that I would love for you to flesh out a little bit about mastery and about communication mastery. And I know that a lot of physicians come to our unit and ask to come and speak and work with us in palliative care because they're trying not to just learn the skills, they're trying to master it. And so would you happen to have something to say about what's the difference between just learning how to talk and mastering the skill?
Yeah, that's a really difficult question. I think that we all come whether we all grow up learning how to talk. I think the thing that maybe defines mastery to some degree, or at least moves in that direction, is this idea of what I call sort of spatial awareness that I mentioned in the talk. Kind of when I think about what I'm trying to train palliative care clinicians to do in a room, whether it's with a family or with an individual or a couple, is to really have a sense while it's happening of what is happening. So almost as if you were the fly on the wall observing what is happening and being able to look around the room and understand the different emotions, the different reactions of the people in the room, and adjust your use your communication skills appropriately for the right tool at the right moment. And I think that spatial awareness is something that is really important for us to cultivate, because often, if you think about some of our standard procedures in palliative care, family meeting is like the classic one. And really you're trying to balance the communication needs of a lot of different people. There's different information needs, there's different emotional needs, and our ability to sort of recognize what they are in real time and recognize how we are going to respond is probably as close as I can get to a definition of mastery.
Thank you for that.
Thank you, Dr. Sanders. We actually have a question on the chat that I will, it's from Sandrine Bernard. So she's written it in French, so I'm going to translate it. So she's curious about how we can support patients to have some of these difficult conversations when you're faced with a situation where the family is interfering with us, speaking about the illness or the prognosis with the patient. She remarks that many families are worried that if the patient knows that they are at the end of life or dying, they'll be discouraged and they will sort of give up. And so she feels that this denies the patient this ability to do some of the work and kind of come to terms as you were describing.
Yeah. No, I think that's very common for families to want to protect their loved one from that information. And it is also true, to add to what you said, that it can be very isolating for patients who have a sense about what's happening to them, for no one to address it, for their doctors not to address it, for their family members not to be able to talk about it. And at the same time, they also want to protect their family members and not make them feel sad. And so there's a lot of sort of collusion in some ways, unspoken collusion around not upsetting people in this in the setting of serious illness. And I think that one of the things that can be really useful is to name this with family members, and to name the dilemma is another sort of thing that we talk about, which is to say, I feel a dilemma here. On the one hand, I hear that you are really wanting to protect your loved one from the potential sadness and maybe even some health effects of having this information. And on the other hand, it can be really isolating for people not to have the opportunity to speak about these things with their loved ones, with the people that they care about and who care about them. And so, help me think about what kinds of, you can take it to other experiences. Help me think about how you managed difficult conversations as a family in the past. What are you most worried about? Tell me more about your beliefs about how information might affect their health. Really trying to get into it, I think, and I think that family members, in my experience, really appreciate the kind of this kind of dialogue that's deeply respectful of what their beliefs are. We're not saying that's absurd. Information doesn't kill people. We're really trying to engage with them in a discussion about all the meaning of what's happening.
Thank you very much. I'm just cognizant of the time, so we will take one more question, and it's in the chat. So Mark Clark says that mastery sounds a lot like listening. How do you teach people to listen? And then a follow-up question: how do you prepare for a difficult conversation? How do you clear your mind so you can listen and be there for the patient and family? And how do you do this repeatedly throughout the day?
Okay, these are great questions. I'm going to try to hold them in mind. So it's I would distinguish mastery from listening, at least by the definition I gave, which, some people may disagree. But it involves a lot of listening, but it also involves seeing. And it's a type of, in some ways, it's about the, again, this spatial awareness, this awareness of what's happening as it's happening, which certainly requires a lot of listening and seeing, I would say, about what you're seeing. What does it mean when the family member to the left rolls their eyes and turns their head away? What does it mean when one family member is saying the patient says one thing and their other loved one drops their head down and turns away? These are the kinds of things that you're looking and listening for to see how to respond, who's having emotion where, and how to make it all work in some way. I think when it comes to, how I prepare myself, I had a great teacher in medical school who would talk about sort of pausing at the door and taking a deep breath before going in, whether it was in the outpatient setting or the inpatient setting. And I find that really valuable to take a pause, because you're in some ways kind of honoring that moment. You're saying, okay, I'm going to go in and I'm going to have a conversation with a family, and this may not be what they're expecting. There may be information that may come out of the blue. They may be really emotional, and I'm just going to prepare myself in some way. I'm going to take a deep breath. Now, how do we do it all day? I think even palliative care doctors don't do this all day long. And we have our breaks and our more, simple encounters. But I will say that part of it is an orientation towards the idea that what I'm doing is sort of at the very core of what I believe a doctor should do, which is build relationships with people. And it's kind of this amazing privilege that we have to relate to people from all walks of life around this incredibly important, at this incredibly important time in their life. And I find that to be incredibly rich. And so I kind of, I find it to be, as I spoke recently about to a group of volunteers, kind of a refuge, like to be able to sit down with family members and not worry about going into these rooms and having these difficult conversations, but really, utilizing my skills to help them make sense of what's happening. And I think at the end of the day, we're all just trying to get through, our lives with some sense of meaning and integrity. And I think that we get to do that all the time. And so I find it, it can certainly be emotionally draining, especially when you're working really hard to track and respond to all that's going on around you. But there are those times when I'm doing that and I feel my video game life points sort of going deep, 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 deep. And I'm conscious of it. And I say, okay, this is worth the energy that I'm spending right now. And in that I get something from it as well. And so, I really encourage people to lean into these conversations, because they really, as much as or more than anything else, help us build relationships with people that help sustain us in our work, and that I think, are kind of a key to our sustainability as clinicians.
Thank you so much. Certainly this conversation could go on much longer, but I will bring it to a close, let you get back to sunny California, and give us the opportunity to take a short but essential break. So for those of you in the room, there is coffee and drinks and some food next door. So please help yourselves, take the opportunity to stretch, go to the bathroom, and come back in exactly 10 minutes. So we'll start right at 10:30. Well, maybe 10:32 because it's 9:22. And we'll proceed with our day. Please don't forget to fill in your evaluation forms. See you soon. Bye, Justin.
Bye, everyone. Thank you.